This particular question is asking for the arrow mark structure which is in the midline, and that is actually the fornix, which is anterior relation of the third ventricle sandwiched between the two thalami. Here are the two thalami sandwiching the third ventricle in the midline, and fornix is at the anterior relation of the third ventricle, though it is also the roof of the third ventricle and it comes anterior, so that will be the fornix. Our answer should be choice number A here. It is the major output tract from the hippocampus, also comes as a question. The other things which you can see is this V-shape internal capsule on either side, which is sandwiched between lentiform nucleus lateral, that is for the basal ganglia. This is the lentiform nucleus which is lateral to the internal capsule on either side. And here we have got the head of the caudate nucleus on either side. You can see that anterior limb of internal capsule is sandwiched between caudate medial and lentiform lateral, whereas posterior limb of internal capsule is sandwiched between lentiform lateral and thalamus medial. And this is the bend called genu of the internal capsule. Now, as such, the marker was asking for fornix, and we have already given our answer. Plus, we have added some more details in this area. You may also be asked about the claustrum, and claustrum is some gray matter which is still more peripheral, the most peripheral gray matter in the territory of this transverse section of the brain, if you go lateral to the lentiform nucleus. As you find, it is asking for the marked artery in this diagram. It is the circle of Willis at the base of the brain. You can notice that this is the basilar artery which is running at the base of the pons and giving some branches. It has already given anterior inferior cerebellar artery to the cerebellum here. Then it is giving the superior cerebellar artery which is seen on one side clearly. Then it is bifurcating into two branches. That is the posterior cerebral artery, one on each side. And it is the posterior cerebral artery, which is branch of the basilar artery, the terminal branch, is receiving this branch which is called as posterior communicating artery, which itself is a branch of internal carotid artery, one on this side, one on that side. It may happen that the lumen of the posterior communicating artery may be variable, small lumen here and large lumen on the other side. So that is also posterior communicating artery, but on the other side, a branch of the internal carotid artery. And here you can see internal carotid artery giving the middle cerebral artery, which is the major artery to the lateral cerebrum, seen on both the sides here, middle cerebral artery. Internal carotid artery is also giving anterior cerebral artery, which can be seen now. Here you see these are the interior cerebral arteries which have come from the internal carotid artery, and they are going towards the anterior aspect of the cerebrum there. The major artery to the medial cerebrum, anterior cerebral artery. And here is circle of Willis, which is contributed by 9 arteries. There is 2 anterior cerebral artery, 1 anterior communicating artery, 2 internal carotid arteries, and there are 2 posterior communicating arteries, and then you also have posterior cerebral arteries, which are terminal branches of basilar artery here. So basically this arrow mark was on the posterior communicating artery, which we wanted to find out, and you can see one diagram later to the same. It's a schematic diagram now. So as we wanted to make out this posterior communicating artery, you can see this is the posterior communicating artery, and the one on each side. As I said, that the lumen may be variable on either side. This posterior communicating artery will be actually the branches of internal carotid artery here on either side. You can also make out the basilar artery here, giving the posterior cerebral arteries which were actually communicating with the posterior communicating arteries here. So we'll keep our answer as posterior communicating artery. Internal carotid artery has given some branches like middle cerebral artery going to the lateral cerebrum, and it is also giving anterior cerebral artery going to the anterior cerebrum. And these anterior cerebral arteries, they are connected to each other by anterior communicating artery. So here we have 9 arteries making circle of Willis. There are 2 anterior cerebral arteries, 1 anterior communicating artery, 2 internal carotid artery, 2 posterior communicating artery, and the 2 posterior cerebral artery, making the circle of Willis at the base of the brain. And our answer should remain posterior communicating artery. Presently, it is asking about the structure marked here with the arrow. If it is damaged, then which kind of muscles will be compromised? We have removed the cerebellum from the roof of the fourth ventricle, looking at the floor of the fourth ventricle, where you have upper half of the medulla oblongata and also the pons as such. In the lower pons on the dorsal side, there is a rounder elevation, which is called as the facial colliculus. And deep to this facial colliculus will be the axons of the facial nerve. If the facial colliculus is damaged, the axons of the facial nerve damaged, muscles of facial expression will be compromised like risorius. So our answer should be risorius. But also understand that if the lesion goes deeper, there is a deep nucleus, which is the abducens nucleus, and abducens nucleus can also get compromised, leading to paralysis of lateral rectus. So lateral rectus could also get involved, but if it is a deeper lesion. Actually, there is a facial colliculus syndrome in which both the axons of facial nerve and the abducens nucleus gets involved. But if you have to choose between the two answers, risorius or lateral rectus, the first answer should be risorius, because you have to understand it is a muscle of facial expression controlled by the facial nerve, which is producing this rounder elevation called facial colliculus at the floor of the fourth ventricle dorsum of the lower pons. So we keep our answer as risorius here. As such, this question is asking for inhibition of some structure which is marked by this the arrow mark. This is actually the Purkinje cells, and Purkinje cells are the cells which are sending dendrites towards the outer molecular layer of the cerebellar cortex. Cerebellar cortex has three layers: the outer molecular, middle Purkinje, and the inner granular layer. If you talk about the cells there, you'll find there is stellate and the basket cells, which are in the outer molecular layer. Middle is the Purkinje layer, and inner is the granule layer, will have GG cell, the granule, and Golgi cell. Now, as the arrow is pointing towards the middle layer of cerebellar cortex, it is the Purkinje cell. Purkinje cells are using GABA, gamma aminobutyric acid, on the deep cerebellar nuclei like dentate nucleus. So out of the 5 cells in the cerebellar cortex arranged in 3 layers, only 1 cell has the outgoing fibers, and that is the Purkinje cell, and which is sending the negative neuroinhibitory fibers using GABA on the deep cerebellar nuclei like dentate nucleus. And that's why we will search for the dentate nucleus, and the answer should be deep cerebellar nucleus here, using the gamma aminobutyric acid on that. If you're talking about the Golgi cell, it will be in the deeper granule layer. If you're talking about the basket cell, it will be in the outer molecular layer, but the Purkinje cell is not inhibitory on any of those. So we keep our answer as choice number D here, the dentate nucleus or deep cerebellar nucleus. Presently, this question is asking for marked area and some intracranial hemorrhage and some artery. It is a pterion which is H-shaped suture. The 4 bones are articulating: front frontal bone, posterior parietal bone, inferior temporal bone, and greater wing of the sphenoid. Deep to that is anterior division of the middle meningeal artery. So our answer should be choice number B as such, and let us have a look over a diagram as well. As you can make out, there is this branch of external carotid artery which is called as the maxillary artery to supply the bone maxilla. It is giving the first part a branch called middle meningeal artery, which is giving anterior posterior division. It is the anterior division of the middle meningeal artery which is under the pterion suture, and it can bleed to give the extradural hemorrhage or epidural hemorrhage. So our answer is anterior division of middle meningeal artery. Deep to the pterion can bleed to give intracranial hemorrhage, and itself is a branch of the middle meningeal artery, branch of the maxillary artery, branch of the external carotid artery. As you find, it is asking for the mandibular division of the trigeminal nerve passing through some of the opening. This is the floor of the middle cranial fossa, showing the opening in the greater vena sphenoid like a round foramen called as the foramen rotundum, and then there is an oval foramen which is called foramen ovale, and then there is a small foramen here, foramen spinosum. So these are the 3 openings in the greater wing of the sphenoid. Understand, the rotundum will have the maxillary nerve passing through that to supply the bone maxilla. The foramen ovale, that is marker B, is where you have the mandibular nerve, branch of trigeminal nerve passing. Not only mandibular nerve is passing, but the male structure will be passing through the foramen ovale. M for the mandibular nerve, A for the accessory meningeal artery, L for the lesser petrosal nerve, and E for the emissary veins. So male structure pass through foramen ovale, that is marker number B, and that is our question asking mandibular division of trigeminal nerve. So marker B should be our answer. Marker A is the foramen rotundum through which the maxillary nerve branch of the trigeminal nerve will be passing. Then what is passing through foramen spinosum? It is the middle meningeal artery. Along with that, a branch of mandibular nerve called nervus spinosus pass the foramen spinosus. Then what is this marker C? That is the foramen lacerum with lacerated margin, and it is covered by some fibrocartilage, so only few emissary veins will be passing through that, connecting the intracranial veins, extracranial veins. And what about the marker D? As such, it is in the posterior cranial fossa and in the petrous temporal bone, the internal auditory meatus for the passage of facial nerve and the vestibulocochlear nerve. So as such, the question was asking mandibular trigeminal. It is the male structure passing through the foramen ovale. That is the marker B should remain our answer. To discuss this, identifying the structure passing through this area which is marked with the arrow, we will just start with the cranial number 1. This is the floor of the cranial cavity after removing the brain, and we can look at the floor of anterocranial fossa, floor of the middle cranial fossa, and floor of the posterior cranial fossa. If you say cranial number 1, which is olfactory nerve, it is coming from the roof of the nasal cavity and piercing the cribriform plate of ethmoid bone. So olfactory nerve axons passing the cribriform plate of ethmoid bone at the roof of the nasal cavity or floor of the anterior cranial fossa. Now number 1. Now number 2 is the optic nerve, which is coming from the orbit here and passing through the optic canal, which is an opening in the lesser wing of the sphenoid. So cranial number 1 and 2. Now when it comes to number 3, this is the oculomotor nerve, which is close to the optic nerve. Number 2, number 3. And oculomotor nerve is coming from the brain stem and is passing into the cavernous sinus here. Along with that, there will be number 4 also, identified by the fact that it will be very thin, the thinnest cranial nerve. So 3 and 4. Then where is the number 5? The number 5 is the thickest cranial nerve and running close to number 4, and it is thickest cranial nerve because it has 3 nerves into 1, lot of axons will come. So thickest cranial nerve is trigeminal, 5th nerve, and thinnest cranial nerve is the trochlear nerve, which is the 4th nerve. Now we have seen the number 1, 2, 3, 4, 5. Where is the number 6? That was our question actually. This is the number 6, or the abducens nerve, identified by the fact that it is puncturing dura mater at the floor of the posterior cranial fossa before it can enter the cavernous sinus and running in the middle of these 2 nerves. Now number 3, 6 and 4. Most medial is 3, in the middle is 6, and lateral is 4. They're all content of the cavernous sinus, and then they'll be passing superior orbital fissure to enter the orbit. So now number 3 and then number 6 will be passing inside the ring of the Zinn, whereas trochlear nerve will be passing outside the ring of Zinn, passing superior orbital fissure to enter the orbit. Now number 3, 4, 6 coming from brain stem and in the cavernous sinus in the superior orbital fissure to enter the orbit, supply eyeball muscles there. Now where is the number 7 and 8? You'll find the number 7 and the number 8 are passing internal auditory meatus in the posterior cranial fossa. Then where is the number 9? The number 9, 10, 11 are actually present in the jugular foramen with the jugular vein, internal jugular vein. Then where is 12th nerve? 12th nerve is hypoglossal nerve in the hypoglossal canal. And here is the fibers of the hypoglossal nerve in the hypoglossal canal, posterior cranial fossa. In the posterior cranial fossa, you can see the number 7, 8 are passing through the internal auditory meatus, number 9 to 11 passing the jugular foramen, and number 12 hypoglossal nerve in the hypoglossal canal. Then what is this nerve which is coming from the vertebral canal and then entering into jugular foramen? This is the spinal accessory nerve branch of the spinal cord and reaching the cranial accessory nerve in the jugular foramen, and then it will go supply the 2 muscles, namely sternomastoid and the trapezius muscle. So here you can see the cranial nerve number 1 coming from the roof of the nasal cavity cribriform plate of ethmoid. Now number 2 is the optic nerve in the optic canal. Now number 3 and the 6 and the 4, they are in the cavernous sinus, superior orbital fissure going to the orbit. Now number 3 is the most medial, now number 6 is in the middle, and now number 4 is lateral. 4 is close to 5 and 3 is close to 2. 2 and 3, and this is 4 and 5. In the middle you have 6 nerve, identified by the fact this arrow is for the abduction nerve. So we can mark it here, choice number B, and identified by the fact that it is puncturing the dura mater at the floor of the posterior cranial fossa. Posterior cranial fossa also has the number 7, 8 passing interauditory meatus, and the number 9, 10, 11 jugular foramen, and the number 12 which is hypoglossal nerve passing hypoglossal canal. We keep our answer as abducent nerve because the arrow is there for marker B. Here we got a question asking for the opening of jaw, which will be depressor of mandible. There are 3 major depressors of mandible. They are the lateral pterygoid and anterior belly of the digastric, and then you also have mylohyoid muscle. And there are 3 elevators of mandible also. The 3 elevators of mandible are remembered as MTM elevators, the masseter and the temporalis and the medial pterygoid. Actually, you can see the MTM elevators in the diagram very quickly, and they help us to close the mouth. This is the masseter muscle which is inserted to the ramus of mandible laterally, and this is the medial pterygoid muscle attached to the ramus of mandible but medially. So medial pterygoid masseter, they have same insertion on the ramus of mandible. One is lateral, one is medial. And along with the temporalis, which is inserted to the coronoid process of the mandible, these are the insertions, MTM elevators. They elevate the mandible and close the mouth. So what is left is marker B here, and marker B is the lateral pterygoid muscle which is attaching to the pterygoid fovea anterior to the neck of the mandible, and it can pull the mandible anterior and it can also pull it down. It is a depressor and protruder of the mandible. If it is a depressor, it will be working with the anterior belly of digastric and mylohyoid and open the jaw. So lateral pterygoid is our answer. Marker B should be our answer. Choice number B remains the answer as such. This is a similar type of a question, but taken a coronal section from the front view. You are looking at the muscles of mastication, and it is asking the marked muscle. You can see that marked muscle is attaching to temporal bone. It is a temporalis muscle, also insert on the mandible bone here. Now this temporalis muscle, one on each side, will be actually the MTM elevators. As you are talking about the MTM elevators, the M is masseter, the other M is medial pterygoid, and T is temporalis, so they are all elevating the mandible to close the mouth. Now this is temporalis, which is an elevator, so we'll keep our answer as elevation, but then you should also know the masseter and medial pterygoid. They are identified by the fact that this is the ramus of the mandible, and attaching to the ramus of mandible you will see there is a medial muscle and a lateral muscle. The lateral muscle is the masseter and the medial muscle is the medial pterygoid. So if you come medial to ramus of mandible, it is medial pterygoid. If you come lateral, it is masseter. M, T, M muscles are elevators from mandible and they close the mouth. Then where is lateral pterygoid here? Lateral pterygoid muscle is actually attaching to the pterygoid fovea on the mandible. It is slightly higher. So this is the lateral pterygoid muscle which is slightly higher as compared to medial pterygoid. Medial pterygoid, lateral pterygoid, they are coming from the pterygoid plate of the sphenoid bone, but one is higher, the lateral pterygoid, which is a depressor of mandible to open the mouth, whereas medial pterygoid is medial to the mandible bone, and it is also working with the masseter and the temporalis MTM elevators to close the mouth. Opening the mouth is lateral pterygoid, which is a depressor of mandible. It can help us open the mouth, along with 2 more muscles, anterior belly of digastric and mylohyoid, working with lateral pterygoid. They are depressor of mandible to open the mouth. So we will keep our answer attaching to temporal bone, temporalis muscle, for elevating the mandible. Presently, this is a question asking about the special sensory supply of the marked area. This is actually floor of the pharynx, where you see the developing tongue, and it is understood that anterior 2/3 of tongue will be developing in the first arch, so it will be having a special sensory, that is the taste sensory supply, from the chorda tympani nerve, branch of the facial nerve. General sensations are from the nerve of the first arch, which is mandibular nerve, branch of the trigeminal, but that is general sensation. If you say special sensation, that is the taste sensation, it will come from the chorda tympani nerve, branch of facial. Now, the second arch will disappear at the foramen cecum, so that it will not be actually contributing general sensation as such to the tongue. When it comes to posterior 1/3 of tongue, you will find that maybe it is the general sensation or taste sensation that will be carried by glossopharyngeal nerve. And when it comes to posterior most tongue or the epiglottis developing in the 4th arch, it will be a branch of vagus which is called as superior laryngeal nerve. Superior laryngeal nerve branch of the vagus will be the taste sensory as well as general sensory for the epiglottis and posterior most tongue. As such, it is asking special sensory, the taste sensation for this marked area. So we'll keep our answer as facial nerve cauda tympani branch. Choice number C should be our answer. Present question is asking us about the danger space, and danger space is the potential space lying between the two layers of prevertebral fascia. You will see this is the diagram which has been magnified here, and it is showing us the same details as such. So let us focus here. What is this marker A? Marker A is actually the nasopharynx. This is the nasal cavity, so nasopharynx. This is the oral cavity, so oropharynx, and this is the larynx, so laryngopharynx. As such, there are three pharynges, and behind the nose, this is nasopharynx. So mark number A is actually the lumen of the nasopharynx. Then what is marker number B? Marker number B is behind the pharynx. So if it is behind the pharynx, then it will be retropharyngeal space. And what about the marker C? Marker C is the danger space, which is actually between the two layers of prevertebral fascia. The prevertebral fascia is going to split into two layers and enclose a space which is called danger space. And what is this marker D? Marker D is in front of the vertebra, so it is called as prevertebral space. Now this is the vertebra. In front of that you have a space which is called prevertebral space, and then between the two layers of prevertebral fascia, which is splitting into two as you see, is the danger space, and in front of that and behind the pharynx is the retropharyngeal space. It is actually a buccopharyngeal fascia, the green color, which is posterior boundary of the pharynx as such, lying by buccopharyngeal fascia. Let us draw this diagram ourselves as well, and to have a better idea, there will be three spaces and three fascia. But as such, as the question was asking danger space, it is here. The choice number C should remain our answer. And let us now discuss this by drawing a diagram ourselves as well. First of all, we'll draw the vertebra here. And in front of the vertebra, you can see that there will be a space. Then we'll find that there is a prevertebral fascia splitting into two layers, and that prevertebral fascia, when it's split into two layers, the anterior is called as the alar fascia and posterior is called as the proper prevertebral fascia. And then there is one more fascia to discuss, which is called as buccopharyngeal fascia. This buccopharyngeal fascia is actually lying as the posterior wall of the pharynx there. So there are three fascia basically. In front of the vertebra, you have prevertebral fascia splitting into proper prevertebral fascia and the alar fascia anterior. A is A, P is P. Proper is posterior, alar is anterior. Then you have buccopharyngeal fascia, which is the posterior layer of the pharynx. Then you have got three spaces also. In front of vertebra, space number A, prevertebral space. Then between the two layers of prevertebral fascia, that is space number B or danger space. And then there is space number C, which is behind the pharynx, but in front of the alar fascia, retropharyngeal space. So three spaces and three fascia. This is going to be the pharynx, lumen of the pharynx. So behind the lumen of the pharynx, you have retropharyngeal space. Between the two layers of the prevertebral fascia, you have the danger space, and in front of the vertebra, you have prevertebral space. As I'm suggesting, in front of the vertebra, you have the prevertebral space. Between the two layers of the prevertebral fascia, you have the danger space, and in front of the alar fascia, but behind the buccopharyngeal fascia, the green thing, you have the retropharyngeal space. When it comes to A, it is the lumen of the pharynx, actually the nasopharynx. So if you say danger space, it is here. Choice number C should be our answer. We find that this question is asking for surface marking for the border of the heart, and it will have four borders. There is a superior border, right border, inferior border, and left border of the heart. Now, before we comment upon the options here, let us have a look over the actual surface marking of the heart first. As we are suggesting, there are superior, right border, inferior, and left border of the heart. You have to start at the costal cartilage number 2, which is at the mandibular-sternal junction, and go to the lower border. So, lower border of the second costal cartilage, on the left side, you start point A and come to point B, which is upper border of the costal cartilage number 3 on the right side. So, this costal cartilage number 2 and costal cartilage number 3. This is lower border, and that is the upper border. This is the superior border of the heart. Then you have the right border. You have to come from the costal cartilage number 3 to costal cartilage number 6, and the slightly convex border, the right border of the heart. Inferior border is marked by a line which is going to reach the fifth intercostal space and slightly medial to the mid-clavicular line. That will be cardiac apex also. And then you can go back to the first point there, and that joining the 2 point will be the left border of the heart. Now we can come back to our question. Actually, we wanted to know costal cartilage number 3 to the 6 is the right border of the heart. So we can repeat the information again. This is the mandibular-sternal junction, left side, costal cartilage number 2. From there you start lower border of costal cartilage number 2, come to the right side and costal cartilage number 3. That will be actually the upper border of costal cartilage number 3. From there you come to costal cartilage number 6. That will be right border of the heart. That's what the examiner is asking, this arrow mark, and that will be costal cartilage number 3 to 6, right border of the heart. And if it comes to inferior border, you can go from the costal cartilage number 6 to the mid-clavicular line, and slightly medial to the mid-clavicular line. That is where we have cardiac apex, or the intercostal space number 5 will be there. So, inferior border of the heart, if you connect these 2 points, then you get the left border of the heart. So, as such, the arrow mark is for the right border. You should say costal cartilage number 3 to costal cartilage number 6 should be our answer. Presently, it is a question on the developing diaphragm and congenital diaphragmatic hernia. Usually, it will be the Bach-Delic hernia they are asking about. And before we comment, let us just look at the developing diaphragm, and then we can come back. This is the inferior view of the developing diaphragm in a transverse section. This is inferior to superior, and you can see most anteriorly will be the central tenor of diaphragm, which come from the septum transversum embryologically, and then you have these two posterolateral membrane, which are pleuroperitoneal membrane. They are forming some component of the diaphragm. Then you also have this dorsal mesentery of esophagus, which will be forming crust of the diaphragm, right crust, left crust of the diaphragm attaching to lumbar vertebra posteriorly, and then there is the mesoderm of the body wall, actually cervical somites coming from the neck region, and they will be contributing towards the large peripheral muscular portion. So there are four components basically coming from the neck region: cervical somite forming the skeletal muscle of the diaphragm. The dorsal mesentery of esophagus will be forming the two crusts of the diaphragm. The problem will be if I have a deficiency in the left pleuroperitoneal membrane, that can lead to Bach-Delic hernia, or Bach-Delic foramen will be here. So the problem will be actually a congenital diaphragmatic hernia. That should be our answer as such. So we can go back to our question now, and we want to zoom this area then. As it will be evident, the marker A is the septum transversum forming central tenor of diaphragm anteriorly. This is marker B, which is pleuroperitoneal membrane, which are forming some part of the diaphragm. This is marker C, which is going to be the dorsal mesentery of esophagus forming crust of the diaphragm. And this is marker D, which is the cervical somite forming the skeletal muscle of the diaphragm. So deficiency was actually in the membrane, especially left pleuroperitoneal membrane. Marker B is our answer, leading to Bach-Delic foramen and Bach-Delic hernia. So congenital diaphragmatic hernia, Bach-Delic hernia, marker B, the deficiency in left pleuroperitoneal membrane. That should be our answer, choice number B. Here we got a question asking about the marker D, and this is about the bronchopulmonary segments. Remember, in the bronchopulmonary segments there are some pulmonary veins which are intersegmental in nature, and that is what they're asking. Marker D here is the pulmonary veins. Otherwise, if you look intra bronchopulmonary segments, then there are three structures, and that will be one artery which is a branch of the tertiary branch, basically segmental branch of the pulmonary artery. There will be segmental branch of the bronchial artery, and also the tertiary bronchus will be there. So inside the BPS you have three structure, but at the periphery you will have a vein, branches of vein called pulmonary veins. Let us have a look at the diagram in detail first before we can mark the answer. So as we would notice, this is one BPS, 2 and 3 BPS, three of them, and what we get is each BPS will be having a tertiary bronchus that will bring in the oxygen. Now if this is bringing in the oxygen, you will send this oxygen into the pulmonary veins, and pulmonary veins are actually intersegmental in nature. As you see, intersegmental nature pulmonary veins, and they will be bringing the oxygen from the lungs towards the heart. So the veins are shown in red color here, intersegmental in nature. Then who brings the deoxygenated blood? The deoxygenated blood is brought from the heart into the lung by what is called as pulmonary artery. So it is shown in blue color. Now blue color artery, pulmonary artery, bring the deoxygenated blood and will be oxygenated and then carried back by the pulmonary veins, which are intersegmental in nature. Now the lung itself requires some oxygen in the proximal part of the conduction system, and that is one bronchial artery brings the oxygen. And there are three structures inside the BPS. They are the tertiary bronchus and the pulmonary artery branch, and also the bronchial artery branch bringing the oxygen for the tracheobronchus and bronchioles region there. As such, the pulmonary veins are intersegmental in nature, and they can be used for surgical resection, segmental resection of a part of the lung. BPS segmentectomy. Following these surgical planes, you can minimize bleeding and minimize tissue damage as well. So as such, marker D, you can see it is the intersegmental structure, which is red color, and it's a vein. It is a pulmonary vein. So segmental branch of the pulmonary vein should be our answer. Choice number C is our answer. Here we got a question asking which type of fibers the muscle is showing here. This is a muscle of lower back, the latissimus dorsi, and inserts into the floor of the bicipital groove in the upper limb. These fibers are 180-degree spiral fibers. As the lower fibers, they go up, and the upper fibers, they low. You will see that the lower fibers of this muscle are going to get inserted at a higher level, 180-degree spiral, and the upper fibers of this muscle will be inserted at a lower level, 180-degree spiral fibers. It is just like the pectoralis major muscle also, which you can have a look now. Pectoralis major, which is a pectoral muscle, it also has 180-degree spiral fibers. As you will notice, the clavicular head, the fibers are coming from the superior, but they are inserted at a lower part of the lateral lip of the bicipital groove. So upper fibers are inserted at a lower level. Similarly, if you look at the lower fibers, which are costal fibers, you'll find that they are coming from inferior, but they will be having a 180-degree spiral, and ultimately they go attached superiorly here at the lateral lip of the bicipital groove. So upper fibers inserted lower and lower fibers inserted upper, and that happens because of spiral fibers. Pectoralis major has the spiral fibers, and same goes for latissimus dorsi also. So in this question, we'll keep our answer as 180-degree spiral fibers, just like pectoralis major muscle. What you find here is identifying the medial cord of brachial plexus in the image. Actually, this is the humerus bone, which is lateral bone, the scapular bone, which is posterior bone, and the ribs, which are medial bone, and it is the axilla. If you say lateral, it is the humerus bone. If you say it is medial, the ribs, and if you say posterior, it is the scapular bone. So we are basically talking about the medial cord of brachial plexus, which will be lying medial to the axillary artery. Relation to axillary artery, there are three cords of brachial plexus. One is lateral, one is medial, and one is posterior. So that is what we want to talk about. Before we answer the question, you just have a look over the actual diagram. So as I'm suggesting, lateral wall of axilla is the humerus bone, the armpit lateral boundary, and if you say the ribs are on the medial boundary. If you say the scapular bone, which will be posterior boundary, and anteriorly you will have pectoral muscles there. So pectoral muscles are anterior, the serratus muscle on the ribs is medial, and subscapularis muscle on the posterior scapula is posterior wall of axilla. That will be axillary artery. Later to axillary artery, you have three cords of brachial plexus, lateral, medial, and posterior cord of brachial plexus. Here we have taken a section of the axilla like this, and you can find the lateral bone is the humerus bone, and the posterior bone is the scapular bone, and medial bone is the ribs. Attaching there is serratus anterior muscle coming from ribs to the scapular bone. So serratus anterior and the ribs are medial boundary. Scapula is posterior boundary with the subscapularis muscle in the posterior wall of axilla. Anterior wall of axilla is pectoral major and pectoral minor. Now this is the orientation. You will see that this is the area where we were talking about axillary artery. Medial to that is axillary vein, and then you will find there are three cords of brachial plexus. If it is behind the axillary artery, posterior cord. If it is lateral, lateral cord. Now the point is, medial cord of brachial plexus is not exactly medial. It is anterior to the artery. So that can create confusion. Let me zoom this area again. As I'm suggesting, this is axillary artery, and medial to that is axillary vein. So where is the medial cord? It should be medial. It is not exactly medial, it is anterior. So medial cord of brachial plexus is not exactly medial, it is anterior. And lateral to that, lateral cord of brachial plexus. Posterior to that, posterior cord of brachial plexus there. And what is this nerve? That is nerve to serratus anterior in the axilla. Now let us focus upon the same details in our diagram in the question as well. And as we zoom this area a little bit more, you can notice that humerus bone is the lateral bone, medial bone are the ribs, and posterior bone is the scapular bone. On the scapular bone, you have subscapularis muscle, which is posterior wall of axilla. And the lateral wall, you have the ribs and the serratus anterior. Laterally, you have the humerus bone having attachment of pectoralis major, which come from the costal cartilage and to the humerus bone, like that, anterior wall of the axilla. Now, with that orientation, you can see this is axillary artery related to the three cords of brachial plexus. Behind that is posterior cord. Lateral to that is lateral cord of brachial plexus. Though the medial cord should be medial, but it is not medial, it is actually anterior to axillary artery. So the choice number C should be our answer, because they were asking us about the medial cord of brachial plexus. And what is exactly medial to the axillary artery? That will be axillary artery. This is axillary vein. And what is this nerve here? This is nerve to the serratus anterior muscle. The marker D is that. So where is the medial cord of brachial plexus? It is not medial, it is anterior, and marker C should be our answer. So here we'll keep our answer as choice number C there. Presently we are having a patient who is unable to flex the distal interphalangeal joint in the finger number 4 and 5. If you want to flex the DIP, then it will be flexor digitorum profundus, and flexor digitorum profundus for these fingers is actually supplied by the middle half of FDP, supplied by ulnar nerve. So this appears to be ulnar nerve injury. And moreover, the patient is unable to hold card between fingers. That is palmar interossei, which will be holding the card between fingers. And if it is not happening, remember the palmar interossei or the dorsal interossei, all the 8 interossei, 4 palmar and 4 dorsal, are supplied by ulnar nerve. So it is obviously ulnar nerve injury. Ulnar nerve is related to the behind medial epicondyle. So it may be a fracture of the medial epicondyle nerve passing behind that could have been injured. Now the head of the humerus is looking medial, so this should be the medial epicondyle, marker number D. Behind that will be passing the ulnar nerve. Then what is related to the marker number C? In front of that lateral epicondyle will be the radial nerve. And what is behind the marker number B? That is mid-schaftner humerus. Behind that is radial nerve in the radial groove. And what is that marker A? That will be the axillary nerve in the surgical neck of the humerus. Let us have a view of the nerves in the diagram at present. So as we are suggesting, there is the three cords of brachial plexus in the axilla. The medial cord continue as the ulnar nerve, and passing behind the medial epicondyle can be damaged. And the radial nerve, which is continuation of the posterior cord of brachial plexus, go posterior to the bone humerus, come anterior to the lateral epicondyle. And then there is also a branch of the posterior cord called axillary nerve going around the neck, surgical neck of the humerus bone. And as such, we are having a problem with the ulnar nerve. Ulnar nerve, which passes behind the medial epicondyle, can be damaged here in a fractured medial epicondyle, paralyzing the medial half of flexor digitorum profundus, inability to flex the DIP joint of these two fingers, number 4, 5. Also, since ulnar nerve is compromised, 4 palmar, 4 dorsal interosseous compromise, 8 interosseous ulnar nerve compromise, and difficulty in holding the card between fingers. Of course, that is one of the feature of palmar interosseous compromise. So that is our question. Let us go back to the question now. So as we suggested earlier also, medial is the head of the humerus and medial epicondyle is here. So marker D should be our answer. Choice number D should be our answer. It is ulnar nerve injury case as such. Here we got a question asking, which is the skin supply to the dorsum of the hand, 3.5 fingers. Obviously, it will be the radial nerve, but it will not supply the nail bed because nail bed will be already supplied by the median nerve. Let us have a look over the diagram and then we can come back to our question again. We need to understand that dorsum of the hand, 3.5 fingers, will be supplied by the radial nerve but minus the nail bed, because nail beds are supplied by the median nerve as such. 1.5 finger, maybe the dorsal or ventral, will be supplied by ulnar nerve. Let us look at the ventral aspect as well. So here, as we can make out, 3.5 fingers anteriorly will be the median nerve and 1.5 finger anteriorly will be ulnar nerve. Ulnar nerve not only supply 1.5 finger anterior but also posterior. So that will be ulnar nerve both places. But when you say median nerve supply 3.5 fingers anteriorly, they also encroach upon the nail bed posteriorly. So nail beds are under the median nerve, whereas dorsum of the hand, which is 3.5 fingers minus the nail bed, will be the radial nerve. That gives us our answer. So in this particular question, our answer will be radial nerve. Choice number C should be our answer. This is a question which is asking us about some muscles in the hand, and as we will zoom out, it will be understood that these are some muscles which are coming from the tendons of a muscle attached to distal phalanx there. As it is made out that they are coming from the tendon of a muscle, the tendon which is attaching to terminal phalanx, FDP muscle. So it is the tendon of flexor digitorum profundus, which itself attaches to the base of the distal phalanx to fold the distal interphalangeal joint, flexor digitorum profundus tendon. But then it is giving some muscles here in the hand, 2 lumbricals which are unipinnate and 2 lumbricals which are bipinnate. So as you can see, these are unipinnate muscles, the 2 supplied by median nerve, and there are the bipinnate muscle, the 4, 5 fingers, and that is supplied by ulnar nerve. So these lumbricals which are bipinnate are by ulnar nerve, and these lumbricals are by median nerve. All of them coming from the flexor digitorum profundus, which is a hybrid muscle, middle half supplied by ulnar nerve and lateral half supplied by median nerve as such. So as we can make out, coming from the tendons of FDP, there are 4 lumbricals. Our answer should be choice number A here. The present question is asking about the transversus abdominis muscle, looking from the lateral view, and the conjoint tendon. Conjoint tendon is actually 2 muscles contributing. One is the internal oblique muscle and the deeper transversus abdominis muscle. And you will notice that before we comment upon the answer, we should look at a diagram. So it is a lateral view of the transverse abdominis muscle whose fibers are going transversely, and the origin is thoracolumbar fascia on the posterior side, and then it is also taking origin from the lower ribs here, inner surface of lower ribs, and also taking origin from the hip bone, that is the iliac crest on the hip bone. So that is the origin. Insertion is into the rectus sheath covering the rectus abdominis muscle on the anterior abdominal wall, the linea alba and all that. Now what happens is, as this muscle come here, attaching to the pubic bone, it will be forming a conjoint tendon along with the internal oblique muscle. So this is the point where you have the conjoint tendon, and that was the marking which we were talking about. There is a linea alba in the midline. This is linea semilunaris, where you'll find the muscle fiber become aponeurosis, and then you can see this is thoracolumbar fascia, which is giving origin to the muscle. There is an inguinal ligament also, which is having some fibers attaching to the transversus abdominis muscle. Inguinal ligament attaches to anterior spine, hip bone, and the pubic tubercle on the hip bone there. So as we can see, this is the marker A, thoracolumbar fascia, and then it is the marker B, linea semilunaris, where you see the muscular fibers becoming tendinous, and marker C, the inguinal ligament, and marker D is the conjoint tendon there. Our answer should be choice number D, the marker D. Present question is showing the lever here superiorly and the first part of duodenum inferiorly. Between them there is opening the epiphytic foramen of Winslow. It is a lateral view for the epiphytic foramen of Winslow, lever superior, duodenum inferior. But we want to have some more details of this foramen of Winslow now. As you take a sagittal section of the abdomen region, you'll find this is lever superior and the stomach or duodenum inferior. Between the two you will have epiphytic foramen of Winslow. There are three structures which are anterior, and there are three structures which are posterior. So what are the three structures anterior, posterior we want to see? Magnify this area and here. As you will notice that we are having the DAV structure anterior, duct artery vein, running in the free margin of porta hepatis and related anteriorly to the foramen of Winslow. D for duct, bile duct, A for artery, hepatic artery, V for vein, portal vein. Three structure anterior. And what are the three structure posterior behind the foramen Winslow? That is actually T12 vertebra, right adrenal gland, and inferior vena cava. Three structure posterior. There is the L1, the lever 1 superior, and D1, the duodenum 1 inferior. First part of duodenum is inferior and first part of lever is superior. First part of lever means caudate lobe of lever is superior. So this is the foramen of Winslow, which is a communication of the greater sac with the lesser sac. So basically this question is upon the foramen of Winslow. You'll find that there is portal vein anterior and the inferior vena cava posterior. Actually these two veins were running together, then they split to enclose this foramen. Anterior vein, portal vein, posterior is inferior vena cava. There are some more structure behind inferior vena cava with the right adrenal on T12 vertebra, and DAV structures are anterior, running in the free margin of lesser omentum, going to porta hepatis of lever. The D1, duodenum 1 is inferior, L1, the lever 1 is superior. Caudate lobe of lever is superior, and first part of duodenum is inferior foramen of Winslow. So we'll keep our answer as choice number B here. The question we are looking at is asking us about the dermatome, the shaded area, green area. It is the periumbilical region. So T10 dermatome should be our answer. When you say T10 is your answer, it is the midgut pain, could be the pain of acute appendicitis or Meckel's diverticulum. If you say so, then what is the pain of the foregut? We are going to zoom this area now, and you will notice that when it comes to the foregut pain, it is T7 epigastrium. And what is the nipple level? It is T4. And what is the shoulder tip? It is C4. Shoulder tip is C4, C4. Nipple level is T4, T4. Epigastrium is T7, the foregut pain. And the midgut pain is periumbilical T10. And inguinal region, L1, is the hindgut region in the midline. So for this green shaded area, we'll keep our answer as T10 here. The present question is asking us about the pelvic diaphragm, that is levator ani muscle. It is like a support of the pelvic viscera to support like urinary bladder, uterus or rectum, and that is going to be a muscle which is here. So marker B should be our answer. And also remember that it is basically forming the middle boundary of the ischiorectal fossa. Now before we talk more about ischiorectal fossa, let's look at a diagram first. You have to look from the posterior side, and this area, ischiorectal fossa, actually ischium bone on the lateral side and rectum in the midline. So here, this is the rectum which is in the midline, and you will find ischium bone is lateral. Ischiorectal fossa is a space which is lateral to the rectum and middle to the ischium, and it is having some boundaries which we want to see. So here we can see again in the midline we'll have the rectum becoming the anus, and the lateral bone will be ischium bone. Attaching to ischium bone is a muscle called as the obturator internus muscle. So obturator internus muscle is the lateral boundary of the ischiorectal fossa, and it has obturator fascia. On the obturator fascia you have the pudendal canal. In the pudendal canal you have the pudendal nerve and pudendal vessels. They are in the lateral wall of the ischiorectal fossa. Then what is the superior medial boundary? It is the levator ani muscle which is making the pelvic diaphragm. And if you come more medial, then you'll have this external anal sphincter. So external anal sphincter is medial, superior medial is the levator ani muscle making pelvic diaphragm, and lateral muscle is the obturator internus with obturator fascia with the pudendal canal in the lateral wall on the bone ischium. If you come to this fascia, it is called as anal perianal fascia. This is what we wanted to understand to describe our diagram there. So as we come to this question again, let us zoom this area, and you can make out this marker A is obturator internus on the ischium bone laterally. B is the superior medial boundary which is the levator ani muscle making the pelvic diaphragm. Middle it is also the external anal sphincter present there. If you say laterally, the obturator internus has obturator fascia. In the obturator fascia you have pudendal canal. In the pudendal canal you will have pudendal nerve and the vessels. This is anal preanal fascia, the marker D. And what is marker C? Marker C is the internal anal sphincter, and lateral to that will be external anal sphincter. So where is pelvic diaphragm? It is this area, that is levator ani muscle, called so because if it is contracting it can elevate the anus. So levator ani muscle make the pelvic diaphragm, and that was our marker B as the answer. You can see which is forming the pelvic diaphragm, that is the levator ani muscle. Marker B should be our answer. Here we got a question asking about some muscle attachment on the lateral surface of the greater trochanter bone femur. This is posterior view of the femur. This is the intertrochanteric crest, the lesser trochanter, greater trochanter. Lateral surface of greater trochanter you have some gluteus muscle attaching. There are three gluteus muscles you can see. The gluteus maximus will be attaching to posteriorly, that is gluteus tuberosity. Gluteus medius will be attaching laterally to greater trochanter, and gluteus minimus will be attaching more anteriorly or anterior surface of greater trochanter. Let me show you image of the muscle before we comment upon the options as answer. This is the posterior view of the right gluteal region, and you can see the right hip bone here. This is left hip bone, this is the right hip bone, sacrum bone here. So left side here, right side here, right sided muscle, that is posterior view gluteus medius. The origin is the ilium part of hip bone, insertion is lateral surface of the greater trochanter. Now this muscle, along with gluteus medius, minimus and tensor fascial lata, three muscles, they are going to pull the femur away. They are abductors, and they are also medial rotator at the hip joint. They can rotate the femur medial and medial rotators. These three muscles, which are gluteus medius, minimus, tensor fascial lata, are antagonized by short lateral rotators, which are numerous muscles. That could be the piriformis and quadratus femoris muscle, a quadrangular muscle attaching to femur, quadratus femoris. Along with that, there are gemelli muscles also, superior inferior gemellus, and obturator internus externus muscle. They are all under cover of gluteus maximus. So piriformis or obturator internus externus or superior inferior gemellus or the quadratus femoris, they are all muscles which are short lateral rotators, and they antagonize the three muscles which are gluteus medius, minimus and tensor fascia lata. Basics you should remember. Now as I was suggesting, there are three gluteal muscles. Gluteus maximus attaches posteriorly on the femur gluteal tuberosity. Gluteus medius, which is undercover of that, is attaching lateral surface of greater trochanter, and gluteus minimus, which is undercover of that, is attaching anterior surface of the greater trochanter. These two muscles are basically abductors and medial rotators at the hip joint, but gluteus maximus as such is going to pull the femur back, and it is a chief extensor at the hip joint there. And it also works with the short lateral rotators undercover of that, which I named, that is piriformis, superior inferior gemellus, obturator internus externus, and the quadratus femoris. All of these muscles work with gluteus maximus for lateral rotation at the hip joint. In that sense, gluteus maximus is going to antagonize the gluteus medius minimus because they are medial rotators, and this muscle is a lateral rotator of the hip joint. So what will you say? What about this lateral surface of greater trochanter? That is the gluteus medius. Gluteus medius minimus tensor fasciae lata, they are abductors and medial rotator at the hip joint. So the answer is choice number A. Then who is doing adduction? Their names are adductor brevis, adductor longus, adductor magnus. And who is doing flexion? There's an anterior muscle called as iliopsoas muscle, the hip flexion. And who is the extensor muscle? Chief extensor is gluteus maximus. Gluteus maximus is not only extensor, but it is also lateral rotator muscle. So we keep our answer as gluteus medius and choice number A as the answer. Now we got a similar type of question, gluteal region, and putting our arrow mark here, what muscle is that? Before we comment upon this muscle, let us look at a detailed diagram first. This is going to be the posterior view of the right gluteal region again, and you have removed a large muscle, gluteus maximus, to see the deeper muscles, which are short lateral rotators. These short lateral rotators work with the gluteus maximus as the muscles of lateral rotation, hip joint, and antagonizing the three muscles, which are gluteus medius minimus and tensor fasciae lata there. Let us zoom this area now. The very first thing you are supposed to do is search for the tendon of the obturator internus. So tendon, finding a tendon, it will be easy among all these muscles. In fact, as you find the tendon, that is the tendon of obturator internus, it will be sandwiched between two twin muscles, namely the superior and inferior gemellus. So this is superior gemellus and this is the inferior gemellus. So as you can see, superior or inferior gemellus, the identification is just search for a tendon, and that is the tendon of obturator internus attaching to femur bone. All these muscles, they attach to femur bone, they rotate the femur lateral rotators. So superior inferior gemellus twin muscles you have found. Now go one muscle above and one muscle below. And when you go for one muscle above, that is the piriformis muscle above the superior gemellus muscle here. And if you go for one muscle below, it's a quadrangular muscle attaching to bone femur, and it is called as quadratus femoris muscle. Now all of these are undercover of gluteus maximus, short lateral rotators, antagonizing muscles like gluteus minimus, medius, and tensor fasciae lata. Now as we come back to our question for the gluteal muscles, we still need to magnify this area. And then you can notice that we have got a large muscle, which is gluteus maximus, to see the deeper muscles, which is medius, minimus, and more anterior tensor fasciae lata. But here, your job is to search for this quadrangular muscle, which is attaching to bone femur. Actually, it is quadratus femoris muscle, short lateral rotator with gluteus maximus. Then what will be this tendon of? That will be the tendon of obturator internus muscle. And which muscle will be superior? That is the twin muscle superior gemellus, and inferior, that is the twin muscle inferior gemellus. So searching for the tendon of obturator internus superior inferior gemellus, what is still one muscle higher to that? And that is the piriformis muscle. All of these muscles inserting on the bone femur there. So this arrow mark was quadrangular muscle attaching to femur, quadratus femoris muscle. And we can tell our answer. It is the quadratus femoris muscle. Choice number C should be our answer. The arrow mark here. The question we got here is asking for S2 dermatome. in the lower limb. As you can see, this is the foot, the heel is shown. Remember, the great toe is L4 dermatome, the little toe and heel is S1 dermatome, and this middle area, the calf region and posterior thigh, is S2 dermatome. So our answer should be choice number D, S2 dermatome. If you go more medial towards the medial malleus, it will be actually the L4 dermatome. So L4, L5, S1 and S2 in a sequence. We can repeat the information. If it is the medial malleus you are looking at, then it is L4. Then you come to the great toe, it is L5. Come to little toe and heel, S1. And the calf and posterior thigh will be the S2 dermatome. Our marker was actually calf region, so we will mark it as S2 dermatome as such. So here will be the saphenous nerve branch of the femoral nerve with L4 dermatome coming to medial malleus. This will be actually the medial plantar nerve, which is L5 dermatome for the great toe. This will be lateral plantar nerve, that is S1 dermatome. Also, it is the heel, which is S1 dermatome. This will be posterior gradient nerve of thigh, which is S2 dermatome, choice number D, the calf and posterior thigh. So we'll keep our answer as choice number D here.